So before I turn it over to Dr. Easterling, I just want to give you a little bit of his background. Dr. Easterling served as the first Deputy Commissioner and Chief Equity Officer at the NYC Department of Health and Mental Hygiene. Dr. Easterling has spent more than 6 years in a senior leadership role at the Health Department. And prior to serving as first Deputy Commissioner and Chief Equity Officer, Dr. Easterling served as Deputy Commissioner of the Center for Health Equity and Community Wellness at the NYC DOHMH, where he oversaw programmatic work focused on reducing overall premature mortality and closing the racial gap on the top leading causes of preventable death. He also served as the Assistant Commissioner of the Department of Health's Bureau of Brooklyn Neighborhood Health, where he helped advance key programming to address pressing concerns, including maternal deaths and gun violence. Dr. Easterling is a community physician committed to health equity, social justice, and movement building to achieve the health outcomes that all people deserve, both locally and globally. Dr. Easterling holds a Bachelor of Science from Morehouse College, a Doctor of Medicine from Rutgers, New Jersey Medical School, and a Master of Public Health from Icahn School of Medicine at Sinai in New York. He completed his residency in family medicine at Jamaica Hospital Medical Center in Queens, New York, and a general preventive medicine residency at Icahn School of Medicine at Sinai in New York. So without further ado, I want to turn it over to Dr. Torian Easterling.
Can you hear me now? Okay. All right. Thank you so much, Fashima. Thank you so much for the introduction. It's a pleasure to be joining you all this afternoon for the Lunch and Learn. Certainly, it's always a pleasure, although I am now grounded a lot of ways in New York City. Jersey is my home. I am an Essex County kid, grew up in Newark and East Orange. So really, it's certainly a pleasure to be sharing the work that I've been doing for the past 19 months. But certainly, this is also the moment that we've been in for the past 19 months as well. And it has been a difficult one, but it's also been grounded in a lot of love and resiliency. And so that's also how I come into the work around equity and inclusion, because we can get really technical in how we need to work with people and engage people, but a lot of it is just really grounding in love and compassion and empathy. So with that, is it okay if I share my slides? I can do so now? Okay. Yeah. Oh.
You should be good.
All right. Can you see my screen?
Yes.
Awesome. Okay. All right. So let's go ahead and jump in. Again, I'm Torian Easterling. I have the pleasure of serving in a leadership role at the New York City Health Department. But prior to coming to New York City, to the health department, I was a practicing clinician in Newark, New Jersey at University Hospital, seeing patients, and many of them I'm still connected to today. And so, you know, when we sort of think about, you know, sort of the environment that we're in, the moment that we're in, the bottom line is we're very much still in a public health emergency because we know that COVID-19, the virus itself, SARS-CoV-2, is still circulating in our community. We're all at risk, even those who have been fully vaccinated. And even more so, those individuals who are unvaccinated and are higher risk, and usually those who are either older or younger, or who have underlying chronic conditions such as diabetes or hypertension, certainly make up the majority of the cases that we're seeing right now. We had a period where we saw a decline across the country, and certainly in New Jersey, where cases were going down, our test positivity were going down, our hospitalizations, and thankfully the deaths were nearing zero. But as of about 2 or 3 weeks ago, we started to see those cases go back up. And the fact of the matter is, yes, the classic COVID still exists, but the Delta variant, which is more transmissible, causes more severe illness and hospitalization, is still present in our communities. And because we're now entering into colder months, and so people are less likely to be outdoors, more likely to be around in close quarters with other individuals, and oftentimes those individuals may be unvaccinated, we are seeing cases go up. And as cases go up, typically 2 to 3 weeks later, hospitalizations go up. And so as I've already mentioned, we started to see cases go up about 2 weeks ago. And so as we had expected, those hospitalizations started to inch back up. And so this is the concern. And this is why, really talking about all the different tools that we have to keep people safe, keep people out of the hospital, and certainly keep people alive are the ways in which we talk about how do we protect our community, how do we share the right factual information, but just giving people all of the information on why it's important about getting vaccinated. And so when you drill down, so that was really looking at statewide, really looking at the curve. And I just want to point out sort of the different dips and the peaks in the curves. What we're seeing now is that we are trending up, and we expect that peak certainly will not be as high as wave 1. We pray not wave 2, maybe something similar to what we saw in the summer, where the Delta variant first started to emerge and we started to see cases go back up. Because we have vaccinations in our toolbox, it's really important to understand that we are seeing less cases overall and less hospitalizations compared to the beginning of the wave or the beginning of the pandemic when we did not have those vaccinations. And so I also wanted to draw your attention specifically to Essex County, all right? And so this is the data that not only comes from the State Department of Health, but also the local jurisdictions as well. So as a local jurisdiction in New York State, in New York City, we look at our own data, but you're also able to look at statewide. And so very much so the same in New Jersey, you start to see that the cases begin to creep up in New Jersey. And when you look at deaths are still very low. And again, we still have time. So we have time to intervene. And in order to intervene, we need to do all the things that are going to keep people safe. And we'll get more into, what does that mean, particularly because the holidays are upon us and we're going to have people rejoining one another. And as I've already mentioned, and grounded in where we have been over the past 19, 20 months, and certainly the devastation and certainly the challenges that we've experienced, it is no fault that we want to come together in the next couple of days, and certainly over the December holidays. But it's going to be important that we do not take our foot off of the gas. Right? And so that's just part of the message. What are the things that we must do? So again, before I get there, this question of has COVID-19 pandemic impacted everyone equally? And the answer to that, I think everyone knows, is it has not impacted everyone equally. We know that cases have disproportionately impacted Black and Brown communities across this country, particularly in metropolitan cities. And we know that this isn't a result of, just exposure to a virus, just because of being an essential worker. These are longstanding inequities. And so part of the work that I've been doing is really zero in on those inequities, the risk factors, and how do we assure that there are conversations that we have about dismantling those practices and those systems, but also how do we ground this in what do we need to do right now to protect communities that have been at most risk, that have been disproportionately burdened by this pandemic, and not just thinking about exposure to virus, but thinking about the practices, thinking about the systems that surround people that can keep them safe. And so when you look at certain risk factors, such as one's occupation, one's age, housing conditions. All of these are risk factors in addition to, as I mentioned earlier, underlying chronic conditions. And we know that before COVID-19, in Black and brown communities, we were seeing higher rates of, you fill in the blank of your health outcome, whether it's diabetes or hypertension or obesity or heart disease. So the leading cause of death was not a communicable disease or some infectious disease. The leading cause of death was things that are preventable, things that we know that we can do something about. And we were certainly seeing higher rates in the same communities that have been certainly impacted by COVID-19. So, these are not only the questions, but we certainly need to make sure that we are doing something about it. And that has been my focus. High level view of COVID-19. So COVID-19 is a disease that has been caused by a coronavirus. You should know that coronaviruses are not new. We have other coronaviruses that are circulating in our community. Most older adults are less susceptible to other versions of coronaviruses because they've been around for so long. This novel coronavirus, SARS-CoV-2, first appeared in Wuhan, China in December 2019. And like many other coronaviruses, this virus is mainly spread through respiratory droplets. So when coughing or sneezing or talking. And so as a result of it, we saw transmission begin to spread. We just didn't have a lot of information about COVID-19. There was a lot of mixed information in addition to the misinformation. And so people were saying whether or not to wear masks, or should you wear masks, or you do need to wear a mask, or the proper ways of social distancing, or how much time you could be in someone's presence, in addition to the way that information has been politicized, in addition to the vaccines. And so it made it very, very difficult for individuals to really understand what they should do, how they should engage others. And so we saw how this played out and how we were actually practicing the prevention measures that were going to keep us safe. And then in Jersey specifically, we certainly saw cases begin to rise not long after spring of 2020. New York City really became the epicenter. In New Jersey shortly thereafter. New Jersey is in very close border of New York City and Connecticut. We saw cases go up in spring of 2020. And as I've mentioned before, and you saw in the data on my first slide, as cases increased, hospitalizations were not far behind. And to add on another layer in our response, we absolutely saw inequities in how cases begin to appear, particularly in Black and brown communities. And certainly remember, Essex County being an epicenter even for the state of New Jersey. It's really seeing high cases among residents at that time. And the narrative isn't really just talking about behaviors. The conversation needs to be broader about how systems and practices and longstanding inequities have led to how we know that pandemic takes a toll on communities. And if we do not have the right infrastructure, the right systems in place, and certainly ensuring that people understand how public health works, we're certainly going to see the same result as we saw during this pandemic. And unfortunately, it has claimed the lives of so many people. We've all been impacted by it. But again, we all have not been impacted by it equally. And so the framing is important. And I think the framing of public health is important. The infrastructure which supports and protect all people, and making sure that we can close the gap, particularly when you know that systems are not designed and set up for everyone equally, but also to ensure that we can counter certain narratives. And when misinformation is running rampant, we really have to ensure that we are framing this in a way that can protect lives and really save people. And so we developed this infographic, and this infographic is the way that we talk about how inequities have already existed in New York City, how it caused additional hardship in New York City, and the work that we were trying to do and are still doing to really make sure that we close the gap. So our data is one way in that we can tell a story. And you sort of saw this a little bit earlier from New Jersey. You can talk about cases and hospitalizations, but it's very important that we disaggregate it by race and ethnicity, by neighborhoods, by age, so we can see who's really at risk, who is most vulnerable. And we saw in the data very clearly that by age, we saw that our older adults were most vulnerable. We also saw it by place, and so neighborhoods, particularly low-income neighborhoods, Black, other people of color communities were certainly more vulnerable as well. And this is the way in which we use our data so that we can really ensure that we are driving our resources intentionally. And if we do not, really make sure that we're using it in that way, then we're always going to be blind to how we can really use our public health tools appropriately. And so we drafted an equity action plan. And that equity action plan was really making sure that it wasn't really enforcing the healthcare system, the healthcare delivery system. And so people know that they should go to their doctors for screening and prevention and treatment. And certainly during the pandemic, hospitals became, sort of the central location that people were going to and turning to for answers. But in the public health pandemic, we certainly have to activate all of our partners, not only our healthcare system, but there are so many other assets and resources in communities that really need to be engaged. And so in addition to healthcare system, we know that we have, our providers, our community providers, our federally qualified health centers. How are they resourced? How are they being shared information so that they can communicate to their patients? And as you will remember, many of the community doctors did not have the testing resources, did not have the information to even share with their own patients. In addition, we wanted to expand to our own community-based organizations, very much as the East Orange Y is holding this town hall. How are we activating all of our partners in our community-based organizations, our faith-based organizations? And so funding now is being allocated to community partners to hold space, because they are not only important assets, but quite often they're the right messengers in delivering the message to community to let folks know how they can keep themselves and their family safe as well. And then that message is always important. And we've learned really quickly that if we did not have the right message, if it wasn't simple, it wasn't tailored in a cultural way, if it wasn't accessible as well, then we were having challenges in really ensuring that all communities understood what was going to be important for them to be safe. And so those were the three pillars of our equity action plan. And so we began to tweak it over time, not just for the response and testing and prevention, but also for our vaccine. And so these equity action plans have been somewhat normalized now, and other jurisdictions are creating them and making sure that they're being intentional, so that it's not just about how are you creating plans for everyone, but how are you being intentional of addressing inequities as well. I wanted to spend a quick moment on narratives. And one of the things that I really try to dispel and address, particularly within Black and Brown communities, because when we talk about misinformation, we always go to the Tuskegee experiment. And certainly that was a dark day as far as medical experimentation. And there were other instances in how medical experimentation showed up in communities of color. Even sterilization that happened among women of color, not just Black women, Native American, Latin American women as well. And so this is part of our history, part of the fabric of this country. Certainly Tuskegee experiment was not about vaccines, it was about withholding treatment that we knew could save lives. And we've also seen that in medical abuse, oftentimes those type of structures are reinforced, and how do we address them? And so I always talk about this idea that over the course of history, we've seen how communities have come together. I'm showing a picture of Dr. Dorothy Farabee, who is a member of Alpha Kappa Alpha Incorporated, a sorority that I know has a lot of great roots in New Jersey, and a really strong chapter, not only in New Jersey, but across the country. And it was organizations like the Alpha Kappa Alpha Incorporated, the Black Panther Party, where we really needed to really lift up this idea of community empowerment and self-determination, and making sure that we were delivering services to community members who really needed them. And so I show this picture of Dr. Dorothy Farabee, who was actually drawing blood, but they were also delivering vaccines. And this is in the 70s. And so we talk about how our ancestors were really making strides to deliver vaccines because we knew that it was going to save lives. But things like smallpox, things like measles, then that narrative needs to be told in our own community about how it's really important that we take the lead in really protecting our own families from viruses like COVID-19, but also other health issues that we know exist in our community. And so this is the narrative that I think needs to be lifted up more. And yes, we have to address how medical experimentation has shown up. But when we have facts, I think it's really important that we push those facts forward, and we also connect them to, this isn't something new, that we've seen this before, we've been here before, and what are those tools that we have at our disposal? And certainly community and resiliency is something that's always been something that has been displayed. And so when we look at vaccines are something that we've been expanding and hoping for. Again, going back to March 2020, when we first started to see this pandemic really explode, we were hoping that we would have something like a vaccine to save lives. And so in December of 2020, when the Pfizer vaccine received this emergency use authorization, we had another tool in our toolbox. Certainly wearing masks, social distancing, doing testing, all of those things were important, but it wasn't saving the number of lives that we needed to, because essentially it was delaying people from being infected. And what the vaccines do is prevent people from transmitting, lowering the risk of transmission, and certainly lowering the outcomes of severe illness, hospitalizations, and death. And so it was really important that we had a really robust outreach, a robust engagement to really talk about how vaccines can save lives, the process of having a vaccine as quickly as we have now. We now have 3 vaccines: the Moderna vaccine, Pfizer vaccine, and the Johnson & Johnson vaccine. But how do you make sure that you have an allocation strategy that really gets to those who are most vulnerable? So you saw how it was rolled out for older adults based on your occupation. And then the eligibility criteria expanded from there. And so now we have a vaccine that's available for all adults aged 18 and older. You have one vaccine that is also available for children and adolescents. And so we really need to make sure that we are having conversations and addressing people's questions and concerns. Certainly we know that, factual information is being countered by a lot of misinformation, but also we're seeing how other strategies and policies are working, such as incentives and requirements as well. Part of the focus has been helping people understand how we had this vaccine so quickly, right? And so, I think is always important, as I talked about earlier, how vaccines work, right? Vaccines have been around for decades. Just showed you a picture of Dr. Dorothy Farabee, where they were also distributing vaccines and doing a number of other interventions to really help people. Vaccines are a way in which it gives your immunity or your immune system a boost, a protection from a virus. And so many of us have taken some of the other vaccines that gives us that information so that we have the information necessary to fight off any viruses that we come into contact with. And so the vaccines, the COVID-19 vaccines do just that. You have 2 mRNA vaccines, and then you also have the Johnson & Johnson, which is the adenovirus vaccine. Essentially, those are the delivery mechanisms that sends the protein or the mRNA information to say, you now have to develop these antibodies. And so the understanding of how the vaccine technology could work didn't just start in December 2019, certainly didn't just start when we had vaccines available in 2020. You know, the scientists have been working on vaccines for decades, and we had a vaccine developed after the Ebola outbreak, and there have been so much technology has advanced since then. And so the ability to have vaccines in such a short amount of time really isn't that much of a surprise, because we've had scientists really working on understanding the genetic code of SARS-CoV-2. We had scientists trying to understand the type of technology that we could use to deliver information that will give our immune system the boost. And we have scientists really working on the safety profile of these vaccines. And when you take all of these resources together, right, all the scientists across not only this country, but the world, who are looking at the genetic code of the virus, they're understanding the technology of the vaccine, understanding the safety profile of the vaccine, understanding how we can develop and manufacture the vaccines in large quantities. Everything was really directed to make sure that we had these tools as quickly as possible. And so having it by December 2019 was really because we marshaled all of our resources across the world, given the loss of life, the amount of loss of life that we were experiencing. And this was a true pandemic. And that's what we really have to rest our hat on, that the system worked. The structure that was set up to develop a new biomedical intervention, to make sure that it could be effective, to make sure that it could be safe, we had something that worked. And certainly it has exceeded our expectations in so many different ways. One thing we often hear is that the vaccines have COVID-19 virus in them. And then that is false. The COVID-19 vaccines do not have any COVID-19 virus in the vaccine at all. And one of the things that you should know is that we now have other tools in our toolbox. So the vaccines were developed in 2020, and we now have 3 vaccines. And you may have been hearing in the news how there are now pills that are going to be available. And these are just all these different ways that we can essentially save lives. What you should know, though, and let me just ground this and say that the best assets in saving lives are the vaccines. The pills that will be available, they're not available right now. So before we have vaccines, you would hear that we have monoclonal antibodies. And really the only way that someone is treated with monoclonal antibodies is in a hospital. So you really had to be sick to be in the hospital and be treated with monoclonal antibodies. Now we have vaccines that can prevent someone from minimizing their ability to transmit, but also minimizing their risk of severe illness and hospitalizations. That's truly what we want. And now you also have manufacturers working on an antiviral pill, meaning that if you are exposed, you test positive, you develop symptoms. Now we have a pill that can, even after you are exposed and you're infected, can actually lessen your risk of severe illness and hospitalizations. Those are the outcomes that we absolutely want to achieve. But let me just remind you, the vaccines are the best assets in doing that. But we also know that everyone hasn't been vaccinated. We also know that even if you have been fully vaccinated and 100%, you are fully vaccinated and you have both doses, or the only dose for Johnson & Johnson, no vaccine is 100%. And so we still need to make sure that we're doing everything that we can to protect individuals. I have this slide up because I really want to make sure that I ground this in, we've been doing a lot of work talking about, what the scientists have done, what the academicians have done, what healthcare workers have done. But truly, part of our public health infrastructures are really having true frontline workers, our public health heroes who are out engaging people, sharing information, helping people get tested, helping people get vaccinated. And so I want to acknowledge that the work that goes on in virtual spaces, but also in communities as well. And so, I've been out walking the streets, talking to people, also joining on many of these community events, and you get to hear sort of the flavor of the concerns and the questions, and certainly why people haven't or are hesitant and not really confident in taking the vaccine. Certainly, we're sometimes successful in changing minds and getting people to take vaccines, and sometimes we're not. And so that labor of love is really understanding that we have to be relentless. We got to just keep going. We got to be as empathetic as possible and just continue to knock on those doors, continue to engage people, answer as many questions as possible, and helping understand why this is important. So where we are right now, we are moving in the right direction. You see here in New Jersey that you have 75% of the population at least one dose, and fully vaccinated, really getting close to about 65%. I'm not saying that there's any magic number. Certainly, the higher we get, the better we are, and really being able to curb the spread of the disease and making sure that those who are ineligible, and I have a 1-year-old daughter who is not eligible right now to be vaccinated. So it's really important that those of us who are 5 and older, who's around individuals who cannot be vaccinated, someone may have a severe allergic reaction to a vaccine and is not eligible to be vaccinated. We have to do our part to not only protect ourselves, but then protect others who are not eligible to be vaccinated. And so we still have ways to go. We still have to have more conversations, and certainly this is what we're doing today. So the reminders are vaccines save lives. They've been doing this for decades, and we have to continue to carry that message forward. Certainly, the questions of are they safe and effective? The COVID-19 vaccines are. Data has shown that they have exceeded our expectations in being effective in preventing illness and hospitalizations. And certainly we have not seen any serious side effects. No deaths have been reported. Questions of whether or not they cause infertility, they cause miscarriages, certainly have been debunked. There have been no reports. In fact, we have seen higher risk of poor perinatal outcomes for women who actually have COVID-19 virus, meaning that if a mother actually is infected with COVID-19, they have a higher risk of low birth weight or even preterm births if they're infected with COVID-19. And so really important that we share the factual information so that folks can understand why this is so important. But we are certainly seeing how the misinformation is playing out in communities where pregnant persons have not been vaccinated at a high rate. Across this country, we're only about 35 to 36% of pregnant persons that are actually accepting a vaccine. And so there's a lot of work that we still have to do to dispel those myths, to address those concerns and questions. We know that the vaccines continue to be free all throughout Essex County. Many jurisdictions, they are making them available at a number of different mass vaccination sites, pharmacies, and certainly at your providers. And so we just have to continue to share that information as well. And then one last point, I do want to just take a moment to acknowledge that our physical health is important, but certainly given the trauma and the experience that we just went through, we certainly have to continue to raise the point around making sure that we are paying attention to our mental wellness, our mental well-being, just as important, and the resources that are available. Certainly, not only the COVID-19 line, but also making sure that folks know that there is a mental health line, a suicide hotline, as we've seen increase in reports of anxiety, stress, and also suicidality. And so when we talk about pandemics and epidemics, we're facing a pandemic with the COVID-19 virus, but there are certainly epidemics that we're facing as well, and we cannot take our eyes off of those. And so we have to continue to, focus on, the tasks at hand while also trying to make sure that we're supporting others and the other issues that are coming up. So with that, I will stop there and take questions.
Okay, Dr. Easterling, if it works for you, I could read the questions straight out the chat.
That works for me.
Okie dokie. So we have our first question. Do you recommend boosters for all?
So yes, Boosters are available for individuals 18 and older. In New York City, we actually begin to roll out boosters for adults 18 and older actually before the FDA and CDC actually approved the recommendation. Because as I mentioned earlier, we have to be relentless. We have to keep going. We cannot slow down. We're seeing cases go up. So yes.
Okay, awesome. Next question. Can a vaccinated person who tests negative for COVID, rapid and PCR, carry the virus or infect a non-vaccinated person?
So it's less likely that if someone who is vaccinated and also test negative be a carrier. But it's, I wouldn't say that it's 100%, because we do know that the vaccines are not 100%, and we also know that all of the tests that are available are not 100%. The rapid antigen tests, which people get their results back in 15 minutes, we know that is not very, very sensitive. So we do need to be cautious about the results. So when I say the rapid 15-minute test, you know, the home kit test, the buy next now that you can get over a counter or you get the results in 15 minutes, even if it says negative, you know, and you're still concerned, a PCR test is actually more sensitive, and certainly you would want to do that if you're really concerned.
Okay, dope. Next question. I have been invited to my nephew's Thanksgiving, but he nor his wife are vaccinated. They said they had COVID, so they have the antibodies. I don't want to go because they are not vaccinated. How long are antibodies? How long do they stay in the body after one has COVID?
Ms. Jenkins, I just want to validate your concern. And, you know, I do think it is a real concern that we have to have with our family members who are not vaccinated. I'm certainly having that same conversation in preparation for Thursday, that if someone is not vaccinated because of my one-year-old daughter, I'm not likely going to see them this holiday season. And so we all have to make that decision. We have to weigh the risk and, you know, try not to get into all the details. I will certainly say that a safer environment is certainly staying home, because we are seeing cases increase. If everyone is vaccinated, that is also a safe environment as well. But I would certainly still recommend that people do get tested. You know, this idea of, you know, someone previously infected, they have still a high risk of being reinfected, meaning that they can get the infection again, and they are highly more likely to be carriers than someone who is vaccinated. And this is bearing out in the data. When you look at the data, for those who are, majority of the cases are those who are unvaccinated. So although, you know, your family members may have had the COVID-19 virus in the past, you know, oftentimes those antibodies do wane more quickly than the antibodies from the vaccine. So a lot of this is, you know, a lot of concerns, and it can cause some tension within family. But I think it has to be grounded in, well, I want to be able to have this argument with you another day. And how do I make sure that I'm alive and we all stay safe? Is that, you know, making sure that I make the decision that's best for me.
Excellent. Glenn asked, what effective strategies have you seen or recommend in assisting reluctant individuals towards getting vaccinated?
Yeah, I will say that, you know, that this has been a labor of love again. So there's no one strategy that works. There are multiple strategies that we employ. And certainly I start with, you know, listening and showing empathy. As Chris mentioned earlier, in this brave space, I think it's really, really important to always lean in that way. And the more comfortable that you can be in leaning in starts with you having as much of the factual information so you don't get as rattled, you know, and then it doesn't get into an argument, and just say that, hey, this is what it said, this is what the facts are, this is the data. And some people hold on to their beliefs, and sometimes we just cannot shake them. And then I would also say, which has been really important, has been sharing stories. So I personalize it quite often with my daughter, because I'm a new father, and I really think it's important that I personalize it. And so when you are talking to someone, try to personalize it. Don't try to talk down to them. Don't try to just hit them with all the science and the facts. But I think people need to understand why it's important to you, as you want to hear why it's important to them. So those are just some of the ways that we employ our outreach and strategies. But and also I would say sometimes the one-on-one conversation, because when you have group conversations, sometimes it escalates sometimes. So just
Agreed. We have a few more questions. Is there a wait time to get vaccinated if you're tested positive or had COVID?
So the only thing that you have to be mindful of, so if you do test positive, you should complete your full isolation period. So you should complete the full 10 days. You do not need to be tested after you complete your isolation period, as long as you have no other symptoms, meaning no fever, no body ache, no chills, anything like that. You can just go ahead and get vaccinated after you complete your isolation period.
Okay, next question. I had all 3 vaccines and the flu shot. Can I get pneumonia vaccine or should I wait? I believe was the question.
No, there is no reason to wait. You certainly want to make sure that you time this. So because you have the flu vaccine, you certainly want to talk to your doctor about the right time period between your flu vaccine and the Tdap vaccine. But other than that, no reason for you to wait.
We have one last question before mine. Do you think children under 5 will be cleared soon for vaccination?
I certainly hope so soon. But based on what we're hearing is that children 6 months to 4 years of age will likely not be eligible to sometime in early 2022. I think as early as March or April, hopefully Q1, but we're still waiting for the data and the science to bear out so that we do have a recommendation from CDC.
Okay. Me personally, I have my children are going to get vaccinated. My son is actually turning 12 in less than 3 weeks. So from my understanding, 12 and older get the full dosage, correct?
That's correct.
So I'm like really trying to figure out if I want to get him vaccinated now while he's 11 with a smaller dosage. Like, what's the dosage difference, and is it going to be too much for his body? Because 11 to 12 is just a matter of Tuesday and Wednesday for him.
Yeah. My starting point. I mean, this is I get this question often, and it is a really important question. My starting point is, given where we are, right, and we saw this in the summer when Delta variant emerged. We saw people rush to get the vaccine, and we're seeing that increase now. And so if you want to wait 3 weeks, okay, but I would say go ahead and get the vaccines now. Yes, there is a difference. Certainly that you have, it's 1/3 of the adult dose. So it's 10 micrograms instead of the 30 micrograms that the adults and adolescents will take. But it's not based on your body system or your weight. This is all based on your immune system. So your ability to have the protection. And so we'll know hopefully in a couple of months about the booster dose expanding to younger children. But I think that it's fine for you to take your child now to get their vaccine.
Excellent. I don't see any more questions in the chat. Does anybody want to unmute themselves and ask a question? Oh, Jenny. I think Jenny got a question.
I don't know if she can mute.
Here we go.
I'm sorry, I was trying to type it. I'm slow. I apologize, Torian. Thank you so much. So in our summer camps this summer for Sleepaway Camp, we tested all of the non-vaccinated people every Tuesday. We're a sleepaway camp, right? Like that was kind of what the Department of Health's guidelines were. We have kind of changed some of those guidelines for ourselves now when we're doing short term, right? We're asking everyone to come in with a negative PCR and if they're vaccinated, do an antigen test right now, just so that, we know upon arrival, right? Can you give me kind of some of your thoughts around that as we move forward? Yeah.
Yeah, so just so I understand, so the testing protocol, how is it going to change over time? Yeah, so I would say, I think one thing that's going to change is that we will less likely need to do broad surveillance testing, right? So there's two ways that the surveillance testing works, right? You test every single person, not just those who are unvaccinated, or you test a sample. And usually, because of your capacity and resources, most people are doing testing samples so that they understand how much disease is circulating, as opposed to trying to test every single person. I think as we move forward, as vaccination rates go up, as more children get vaccinated, we're only going to have to test a smaller number of individuals. And I think what's going to change is, if there is exposure, does that mean that the entire camp needs to close? Does it mean, that only a select few who were exposed that would need to close? And so some of the things that we have put into place here in New York is that if a child is vaccinated, that person does not need to go home. They can return to school because they already have a level of protection. And so we'll see some of that guidance change as well, particularly as we start to, expand to 6 months to 4-year-olds, and then we have more information about the boosters. So I expect us to be in a different place next summer. And I think, the question is, how much of those prevention measures do we actually need to implement? We've already been through 2 summers of this, and we've seen, like influenza, that there is a seasonality period. And so we do not have as much circulating transmission of SARS-CoV-2 during the warmer months. So I think we're gonna see some things change a bit.
Okay, we have a couple of questions that just came in. Are there vaccines being developed for those who are allergic to the ingredients in the current vaccines?
Yeah, that's a really good question. To my knowledge, no, not at this point. We have not heard any reports from manufacturers about sort of a different mixture of the vaccines, because it's really hard to sort of pinpoint, a little bit different from like flu, because we do know that if individuals have an egg allergy, there is sort of a rare sort of instance where individuals with egg allergies can be allergic to the flu vaccine. So we haven't really pinpointed if there is an association like that for COVID-19 vaccine. But maybe as we learn more about, individuals, why they're allergic to the COVID-19 vaccine, then we'll get more data there.
Okay. One more question here. What are some of the common side effects experienced for children 5 and up from the smaller dosage?
Yeah, no, really, really good question. So just going back to the clinical trial, and then I'll sort of bring it to the real world experience. But going back to the clinical trial, so there were several thousand children who were enrolled in the Pfizer study. And in the Pfizer study, the most common side effect was soreness on the arm. And so very few actually, actually showed many of the side effects that adults have shown, so the fever, the chills, all the other things that came with the soreness on the arm of the injection site. And that was the purpose around lowering the dose. And so to minimize the reactogenicity of the vaccines. And so real world, we're still seeing that play out. The primary sort of side effect is soreness of the arm, and then also body aches as well. Typically, like other vaccines, pediatricians typically offer parents to give their children either children or infants Tylenol or ibuprofen or Motrin.
Excellent. I don't see any more questions in the chat, and I see we're coming up on our 1 o'clock time frame. Washima, I'll turn it over to you. Thank you so much, Dr. Easterling, answering our questions.
Yes, thank you again, Dr. Easterling. I know you have a crazy, crazy busy schedule, so we really greatly appreciate you coming out to speak to our association today.
Thank you for having me.